So this is the floor plan of the current Stanford Emergency Department. This shaded area is the pediatric area, and then the rest of this is the adult area. And again, just over 11,000 square feet total. And in that, we have 30 treatment areas. And the slide sort of offset there a little bit, but the red stars are our treatment areas. And what I'm embarrassed to tell you is that in addition to those 30 standard treatment beds, we have 7 hallway beds that we use routinely. And that's what the little hearts are indicating here. They're a little bit offset. But these are patients that are being treated in the hallway because we don't have space to get them into rooms and be treated privately where we've got, but it's that or wait out in the waiting room for a longer period of time. And we've opted to try to get care to these patients as quickly as we can by using these areas when we have to. But this is what it looks like when you're being treated in the hallway, not something that we like to see. You can tell this gentleman's not particularly happy about being in the hallway. And it's not something that we like to do. We've talked at times about removing the hallway beds, but again, that would increase the waiting times longer, and that's not something that we want. We'd rather give the patient care as quickly as we can. So what are our challenges? The biggest one, without a doubt, is space, okay? We have inadequate physical plant for today's mission of taking care of the volume of patients and the acuity of patients that we see in our emergency department now. The layout was really never well designed for an emergency department. And I won't go into all the details of that now, but we spend a lot of time walking around a central core area where things are stored. It's not efficient for patient care. And we're landlocked, which means there's not room to just say, okay, let's knock out this wall and build an extension onto the emergency department. There are critical services and other clinical programs all around us, so there's really no place for us to go in the current space. And without a doubt, and this is something that you'll hear more about from Paul Auerbach, I believe, is that we have no surge capacity, okay? If we have, or when we have the next big earthquake, if it happens in the current facility, we really have no place to surge and take an influx of patients. We're already working at maximal capacity almost all the time. This is one of our busiest halls in the emergency department, and you can see we've got 2 of our hallway beds here. Linen cart, computers, things that we didn't have back in 1970s when this facility was built. Again, much less than adequate for what we need. The other challenge that we have is the length of stay in the emergency department. And this is a graph showing our current, this fiscal year's length of stay by month compared to previous fiscal years. And although we did pretty well back in March compared to the fiscal year before, we're still above where we've been in prior years. And what this ultimately leads to, longer waits for people in the waiting area, and much to my chagrin, more people leaving without being seen, making the decision that they don't want to wait any longer for care. And what you see here, the purple bars are the patients who left from this fiscal year compared to the fiscal years previously. And those numbers are up. And the reason that's much to my chagrin is these are people who are undifferentiated in terms of what their medical problem was. And research has shown that not all of these people have minor problems. Some of these people have serious problems that are undifferentiated when they come through, and it's not very clear when they first present that that's what's going on. The other thing that this does is it causes ambulance diversions. Okay? In the last 12 months, if you look at the 2 counties we serve, last 12 months we had 222 hours of diversion, which meant we would not accept ambulance traffic from Santa Clara County, 370 hours from San Mateo County. And the only reason these numbers are different is the EMS agencies for the 2 counties have different rules for how long they'll allow you to be on diversion. For Santa Clara County, they allow us to be on diversion for 90 minutes at a time, and then they force us to open whether or not we feel that it's safe to continue taking patients into an already overcrowded, stressed to the limit emergency department. San Mateo increases that to 2.5 hours. So those numbers are different. Now, these numbers, to be honest with you, well, first of all, I'll say we never divert trauma patients, okay? Given that we are the only trauma center between San Francisco and San Jose, we never go on diversion to trauma patients. These patients that we are diverting would be patients with medical problems that can stop at another hospital emergency department somewhere else along the way. Now, having said this, these numbers are better than most of the country. better than many of the other facilities in our counties. But to be very honest with you, we would prefer that these numbers were 0. And the reason for that, and what I try to remind people, is that our families are out there too. And if we're on divert and one of my loved ones is having a heart attack or a stroke and ends up diverted from us, that's not a good thing. And that's the way we try to approach this. So why are we so crowded so much of the time? Well, this is the page that often goes out on my beeper on a very frequent basis throughout the week. Bed alert level 3, critical care bed alert level 3, meaning we have no critical care beds. The beds are all full in the hospital. And for a long time, people talked about ED overcrowding being a problem with overutilization of the ED by people who couldn't get care elsewhere, didn't have primary care doctors, or were uninsured and whatnot. But that's not what causes overcrowding in the emergency department. ED overcrowding is directly related to hospital overcrowding. Okay? The reason we can't get patients into treatment spaces in the emergency department is because we are boarding more and more patients in the emergency department waiting for inpatient beds. And this is the primary problem that we have, along with the fact that our physical plan is just too small anyway to start with. So what have we done about this? I'm not going to go into all the details here. One of the things that we've done is, thinking a little bit outside the box, is to develop a clinical decision area. What we did was we took 11 beds in another part of the hospital, geographically more remote from the emergency department, so that we couldn't use it as part of the emergency department itself. But we took those 11 beds and put them under the direction of the emergency department itself. And what we do in those beds is we make it a 23-hour observation unit, so that we put patients there that would otherwise have been put into the hospital, and once they would get into the hospital, due to the complexities in the hospital and with patient care teams and whatnot, would spend longer periods of time than if we just take care of them ourselves. And what we find is that if we have a patient, for example, an older patient with pneumonia, and we're a little worried about sending them home, we want to see how they respond to their antibiotics and how they do over several hours of observation, we can put them in this observation unit. We have mid-level providers and attending emergency physicians who are taking care of the patients, as well as our emergency department nurses over there. And then in a matter of some number of hours, decide this patient's either doing well and can go home, or we will need to go ahead and admit from here. And what we're doing is, by doing this, we are saving a significant number of beds in the hospital by not putting somebody up there that would tie up the bed for a couple of days at least. And what we're finding is that we can, for each observation bed we use, we protect 2 to 3 beds in the hospital. So this has been a very effective unit that we opened up last April, and is really helping us facilitate getting patients through the department faster. So that's sort of the clinical thing. What else do we do at Stanford Emergency Medicine? Well, one of the things that we're very active in is disaster preparedness. Global events in the last few weeks, I think, continue to remind us of just how important it is for us to be prepared for when the next big disaster occurs in our area. And so we have a very active disaster and bioterrorism committee that's chaired by Dr. Eric Weiss, one of our faculty in the emergency department. And they meet on a regular basis, planning and putting together action plans for when we have the next big disaster. Preparedness for terrorist acts, bioterrorism. The same committee is very active in this area. This is just one photograph of a recent drill we did at a potential bioterrorist attack using our decontamination equipment that we have at Stanford. We actually, after 9/11, developed a plan that was called Code Zebra, which was specifically a bioterrorism response plan in wake of the anthrax events that occurred after 9/11. And that plan was quickly adopted throughout the country as sort of a model plan to be used by major medical centers. Likewise, we're preparing very hard for pandemic flu and other pandemics that we will most certainly be faced with in the future. Again, Dr. Weiss's group wrote a pandemic flu response plan and came up with a very ingenious way to handle a huge influx of patients that come in, or that potentially will come in once the pandemic starts, that may not be particularly sick, but are particularly worried about what's going on and about what their symptoms may be and what they need to do. And again, that plan has been adopted in many areas throughout the country. And as a matter of fact, we're going to be practicing that plan. I think in June we're going to be having a drill specifically on pandemic flu.